Hi everyone, and welcome to our first video cast of the Psychological Disorders unit. Today I'm just going to give you an overview of what disorders are, how we decide if someone qualifies for abnormal, like what that means in a psychological context, and also a little bit about how we classify and diagnose psychological disorders and maybe some problems that go along with that. So, first things first, I just thought this was an interesting quote, about what it, from someone who is currently a person with a obsessive compulsive disorder, right? And it says, I felt the need to clean my room, spend 4 or 5 hours on it. He liked it, but then he couldn't stop, and the idea that the constant anxiety and that he thought that he was going nuts. So I think that there's maybe a misconception that sometimes people who have psychological disorders don't really know what's going on, and that's definitely the case for some people. They can go into a psychosis and not be aware of what's happening, but for a lot of people, it's a kind of a fine line between just having something that's mildly abnormal and having something that's really disturbing their life and changing the quality of their life. And I think if you think about that for yourself, you probably have some things that you do that are a little bit abnormal, right? Maybe the way that you have to set your alarm clock, or maybe the number of pillows or the number of things that you check, or something that you do normally that might seem a little bit abnormal but doesn't take it to the next level. So just a little bit about, how prevalent this issue is. About 26% of Americans ages 18 and older, so it's like 1 in 4 adults, suffer from some sort of diagnosable mental disorder. It's about 57.7 million people. 6% or 1 in 17, suffer from a serious mental illness. Mental disorders are the leading cause of disability in the United States for the 15 to 44 age group, and nearly half of those with mental disorders meet the criteria for 2 or more. So this is the idea that people are comorbid. One disorder often follows with another one that's very similar to it. And then the most common disorders are anxiety, phobias, and mood disorders. And we're going to talk about all of those categories during the unit. So what does it mean to have a mental disorder, right? How do you know when someone goes from just being mildly abnormal or something that might not be normal to really in the disorder range? The first thing is they have to deviate from statistical and social norms. So the idea for statistical norms is, in psychological context, we put people who are intellectually disabled, and they used to call it mental retardation or gifted, that would be above or below a statistical norm. So they're below 70 or above 140. And for a social norm, it's something that's not common in that society. So an example I have over here is with these the men from a tribe, right? And they wear costumes to attract women. And in our Western society, that might be considered very abnormal, right? Another example of that is, like, in some cultures, it might be normal to, spend a period of time, in the forest, naked, maybe proving your manhood or showing your survival skills. Where in our society, if we had an 18-year-old male who did that, it might be considered like really outside the norm. So you can't judge a person based on another society. You have to judge them based on their society. Second thing is dysfunctional. And dysfunctional can also be shown sometimes as something called maladaptive in some books. And basically it means that you can't function, right? You can't manage daily tasks and activities that are necessary to live. And the last one is distrustful. And this is a harm to themselves or others, and it's usually themselves. A lot of times, we say we think of psychological disorders as scary, but a lot of times they're more harmful to themselves than they are to anybody else. So the 3 qualities, I call them the 3 Ds, just to go over that again. Deviate, right? So they're dysfunctional, they're deviant, and they're distrustful, the 3 Ds. And then, of course, people can have those things, but when is it that you need to get involved? And so we talk about the behavior being pervasive and persistent. So pervasive is that it goes through all parts of their life, right? They don't just have it at work or at home, but it affects everywhere. And then persistent is that it doesn't just happen for one time. It repeats or it continues. obviously if, if someone really close to you dies, you might have some of those things. You might become maladaptive, or, you might, but only for a short period. It doesn't continue and it doesn't repeat. So pervasive and persistent are also important to keep in mind. And the reason I have Paris Hilton and Britney Spears over here is because we think about, like, how pervasive, how often do we see them having breakdowns, or how persistent is it? How often is Paris Hilton in jail or in court, or Britney Spears having a mental breakdown, those kinds of things. So how do we understand psychological disorders and how do we treat them? So a long, long time ago, right, we had these ancient treatments, and they used to include things like exorcism, or caging them like animals, or castrating them, or giving them animals' blood, because a lot of times what they thought is that it was some sort of evil force that was invading the body, right? And this is obviously, if you think of that movie that Leonardo DiCaprio was in, and I can't think of the name, where he has the two personalities, or the two different things that kind of take over. The treatment of the patients there in that one ward where they were like kind of in cages, it almost looked like, and it was dark and dingy. It's actually not that far off from the way that mental institutions used to look a very long time ago, and maybe not even that long ago, like in the early 1900s in the United States. A big thing that came along was Philip Pinel from France. He thought that madness was not due to demonic possession, but really an ailment of the mind, and this came from a more of a medical perspective. And then you have Dorothea Dix, who's the kind of the name that you think of as in terms of like getting patients with mental disorders humane treatment in the United States. And so today we look at mental disorders from, the perspectives. Like we have the hand, right? So you have the biological perspective, which looks at it from a body, a physiological standpoint, right? The brain. You have the psychoanalytic perspective, which looks at it from the unconscious, the hidden stuff. Cognitive behavioral, so what you think, right? And what you've been taught, right? What have you learned in your environment? And then you have the diathesis stress model, which is that it combines a biological predisposition and some sort of stress triggering environmental. So that's the nature-nurture. And all of usually you don't look at it from one perspective, but a combined perspective called the biopsychological social perspective. And this assumes that there's biological, sociocultural, and psychological, like cognitive factors that produce psychological disorders. So you have individual genes that can impact it. It can be passed down, brain chemistry or structure. You have stress or trauma. Those are psychological things, or mood-related perceptions or memories. And then you have sociocultural. So what's defined as normal or disorder, what's expected for you in your culture, and what are the roles that you're supposed to take on. And they all kind of combine to make the psychological disorder. So it's not ever just one thing, although sometimes some factors can be stronger than others in certain disorders, and we'll talk about that. So if someone has a psychological disorder, how do you go about figuring out what it is, classifying it, diagnosing them, so that if they go to a different therapist or if they need treatment, someone will know what it is that they are diagnosed with? So they come up with this book. It's called the DSM, right? Diagnostic and Statistical Manual of Mental Disorders. And this PowerPoint, the most recent edition was the DSM-4 text revision, but actually since then, the DSM-5 is coming out and going to be published, and something that we'll have access to in the real near future. There's already been a lot of publicity about what is and is not in the DSM-5. Every time they come up with a new DSM, they maybe include some disorders or take away some disorders, and so that's data that they keep kind of current with what our trends are. A long time ago, homosexuality was included as a disorder in the DSM, and of course today it's not in there. So it goes along with what is culturally relevant at the time. The most recent edition that, the DSM-4 had 400 disorders, while in the 50s, there was only 60. So it's really changed over time. And what the DSM-4 or the DSM-5 now will do is it gives a psychologist or a psychiatrist or anyone who's working with someone in like sort of a clinical way, 5 levels to diagnose their patient on. So you don't just say like, oh, this person is a person with depression, and then they move on, right? You have to look at their life from various areas and see how what's going on at a lot of different levels. So axis 1 is where you would say the syndrome that you would think of. So they have depression, or they have schizophrenia, or they have an anxiety disorder, OCD, something that maybe you've heard of before. Axis 2 is where you would say that they have a personality disorder or some sort of mental retardation. And today we say intellectually disabled. And that maybe is a little more unclear, and we'll go back to what personality disorders are in a little bit. Axis 3 is where you're going to say if they have a medical condition in addition to the syndrome. So maybe my person has depression, but they also have arthritis or diabetes, and that maybe is impacting their depression somehow. Axis 4, you're going to talk about what's going on in their life. So what are the environmental problems that are present at the time? So maybe they have a death in the family, or a divorce, or they lost their job, and maybe they don't have anything. But a lot of times there's more things that go into the disorder than just a disorder. And the last axis is where you're going to say how functional you think this person is. And it's from 0 to 100. 0 is completely non-functional, suicidal, and then 100 is extremely well functional. So people usually fall somewhere within that range. And here's all the different disorders that will go on that axis 1. So you have, childhood disorders, amnesia, mental disorders due to a medical condition, substance related, so that's substance abuse, drug disorders, schizophrenia, mood, anxiety, somatoform, fictitious, dissociative, eating. These are all things we're going to talk about in this unit. We've already talked about sleep disorders, so narcolepsy and insomnia, those are in the DSM. Impulse control disorders, so that's sometimes talked about like pyromania or trichotillomania, or that's people who pull out their hairs, or you have kleptomania, and there's some other things that can go on there that maybe aren't as well known, like sexual disorders. Okay, so what are the goals of the DSM? They want to provide a common language. They want to describe specific symptoms, so there's a way to know if someone has a disorder. They have to meet the symptoms, and they give a comprehensive guideline for diagnosing. It makes it reliable. So if I send a patient to someone else, they will know what the diagnosis looks like and be able to know certain symptoms about this person, right? But of course, the problem is that the DSM is, it can be used for labeling, which can create a stigma for that person. And someone who really studied this was Dr. David Rosenhan. And what he did is he came up with this study called Being Sane in Insane Places. He had 7 associates go to mental hospitals and say they were hearing voices. And the voices they were hearing were either a thud, right? I'm hearing the voice. What is the voice? Thud. That was it. And all of them were admitted to the mental hospital, and all but one of them were diagnosed with schizophrenia. And they didn't have a disorder. All they had to say was that they were hearing the word thud, and all of a sudden they were labeled, and then once they were admitted to the hospital, they actually acted normal, but they will remain hospitalized for an average of 19 days, right? And the nurses and the doctors in the hospital did not see them as normal. They saw, if they took notes, they saw them as they have paranoid behavior, blah, 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 blah. And so no professional staff member ever realized that these patients were a fraud, okay? The only people who did were actually other patients. They realized what was going on. But then, of course, they weren't really listened to because they were seen as patients, and then that was seen as another part of their disorder. So you have to be very careful when labeling patients, because it can give them a stigma that sometimes we see all their behavior as that disorder when it's not always like that. Okay? So that's all for now, AP Psychos, and remember, psychology is flippin' awesome.